Good afternoon, folks. This afternoon's topic is caregivers supporting loved ones in addiction or severe mental health crises are increasingly turning to firm, clearly articulated boundaries as a survival tool. The article frames this shift not as a withdrawal from withdraw or coldness, but as a necessary recalibration. Limits protect the caregiver's mental and physical health, reduces cycles of unintentional enabling, and create the conditions in which the person in crisis is more likely to accept real treatment. Why boundaries are framed as a lifeline. The surrounding page content emphasizes that boundaries emerge only after caregivers have been stretched to the breaking point. The article describes a caregiver saying, without clear distance and boundaries, he will put me down with him, capturing the fear and consistent reoccurring recurring can become a form of mutual drowning. Several forces make boundaries essential. Emotional preservation. Caregivers report sleep loss, panic, isolation, and the feeling of living in a consistent state of emergency. Limits help them reclaim stability and prevent collapse. Interpreting harm cycles. Well-intentioned help, bailouts, non-stop availability, crisis cleanups can keep the loved one from facing the consequences that motivate treatment. Boundaries disrupt this pattern so recovery becomes possible. Safety and predictability. Limits reduce chaos. They clarify what the caregiver can sustainably offer and what they cannot, lowering the risk of escalation or burnouts. Reframing care. Advocates in the article stress that boundaries are not abandonment. They are a structured plan to keep everyone safer and to support treatment rather than perpetuate crisis. The page content points to several types of limits caregivers are increasingly using. living arrangements, conditions for staying in the home or requiring separate housing when safety is compromised, financial limits, ending repeated bailouts, restricting access to shared accounts, or tying financial help to treatment engagement. Communication rules, setting times when the caregiver will respond, especially during late night crises. That escalate risk or exhaustion. Availability boundaries, clarifying when the caregiver is not on call, allowing them to rest, work, or care for another family members. These examples reflect a shift from reactive crisis management to proactive structure. What the article suggests caregivers approach setting limits. The surrounding content implies several principles. Clinicians and advocates emphasize: be specific and enforceable. Vague statements: I can't keep doing this. Don't create change. Concrete rules do. Communicate the purpose. Limits should be framed as safety measures and pathways to treatment, not punishment or rejection. Stay consistent. Boundaries only work when they are upheld. Inconsistency can reinforce the very cycles caregivers are trying to break. Expect emotional pushback. The article hints at the emotional difficulty or shifting from rescuing to limit setting, but underscores that this discomfort is part of the process of change. When to involve professionals. The article notes that caregivers often experience panic, sleep disruption, and overwhelming fear, signs that professional support is needed. Therapists, peer counselors, and clinicians can help assess safety risks, design realistic boundaries, create crisis communication plans, support the caregiver's emotional health, guide loved ones toward treatment pathways. This professional scaffolding helps ensure boundaries are both compassionate and protective. Key takeaway: the article presents boundaries not as a retreat from caregiving, but as a form of sustainable safety focused care, one that protects the caregiver from burnout and increases the likelihood that the loved one will eventually engage in meaningful treatment. Okay, guys, that's B for you. I will be back on with C shortly. Give me a bit for a little break, and I will see what I can do for a C. For now, Gator Wellness, take care, folks.